Jeff, pharmacists play such an important role in making sure that we're accountable for not just what we prescribe, but the adverse effects of what we prescribe. What would you say for all the provider community out there is kind of a pharmacist leadership role in addressing OIC?
So that's a great question and a great segue from what Brett just said, because apart from the discomfort that people have in discussing constipation in general, I think that one of the reasons that patients are reluctant sometimes to speak to their medical providers is that they're fearful that their opioid medications will be adjusted downward or they'll be switched to another one. And so the patients don't have quite that fear when they're speaking to the pharmacist, because the pharmacist in the community is filling the prescription, right? And so I feel like there's a very open conversation with the pharmacist about it. That, you know, I'm taking this opioid, or this combination of opioids and whatever, and it seems to be working very well for me, but I'm having this horrible problem with constipation. And people have even said to me, I'm afraid to speak to my doctor because I don't want them to take away my medicines. So yes, people do speak to pharmacists quite often about this. I feel like pharmacists need to be more aware about the prevention up front. So pharmacists really should be playing a huge role when an initial prescription comes in for an opioid. They should be having a conversation about a whole lot of things. And I know they're busy, so it's difficult. But I don't feel like anybody should be allowed to sign a pad that says, I decline counseling if there's a prescription for an opioid. I think that it requires a clinician to come down from the back, say, here are the risks of opioids, here's the things to watch for, if there's any problems, you need to do X, Y, Z. By the way, I see that you don't have any prescriptions or you don't have anything with you for constipation. It might be worth your while, if you don't have these things at home, maybe pick up some DocuState and Senna, see if that works for you. If it does not work for you, there are other things that we can do. And so that, I think, is a huge role for the pharmacist, and they can be very, very involved in that.
You know, it was interesting to hear you say that one of the feedbacks that you get from patients is the fear that the opiates that are working for them, that they're doing well with, would be taken away if they pipe up about side effects that they're having. And on the flip of that too, I've had many patients where I think that starting an opiate, even short-term, is appropriate. And the feedback I get from the patients is, I had such bad constipation previously that I'm not going to take your recommendations, even if I think that this is going to help me with my pain.
And so here's another very important role of the pharmacist. If a patient comes in, and this may be a little off topic, but if a patient comes in and they're prescribed an opioid, let's say post-surgical, and they said exactly that. I don't want to take this because last time I was so constipated, I'd rather have the pain than the constipation. The pharmacist really needs to discuss in simple terms the risks of neuroplasticity. If you have had an augmentation of the breast or a wedge resection of the lung or a inguinal hernia repair, these are a C-section. These are all surgeries that come with a high risk of neuroplasticity or chronic pain syndrome if the pain is not appropriately treated. So that's the place where pharmacists can have this conversation with the patient and say, you know, it's really important to keep this pain at bay because it can turn into a chronic pain syndrome if you don't. And if you're fearful about constipation, there are certain things that we can consider.
Well, and also it goes back to stigma, Steve, because I've had patients that have come in and said, well, I went to see another provider and they just told me it was the opioids, so get off the opioids. And I'm blown away to know that that's the education we're giving the patient. You know, whether they know the diagnosis or not, whether they know the reason that they're on it. Providers can be very quick to say, oh, it's the opioids. If you'll just stop that, you won't have constipation, as opposed to treating a problem. And it's not always that easy. And even we see sometimes they'll lower the dose. We know that doesn't work because we know it can be any dose. So it's not just, oh, we'll lower the dose, this gets better. That's not the case either.
I can only emphasize enough the PDMP is a conversation starter, not a conversation stopper. And the scenario, if you get into that chronic pain, can also be the whole hyperalgia, where your sensation becomes more intense with pain that we might necessarily label a 10 out of 10. And I frequently start down workups in the emergency department that are thousands and thousands of dollars because of 10 out of 10 pain, when if we just addressed it early on, we might not have reached that stage.